Dr. Simon Lawson, welcome to the Community Podcast Show.
Thank you, Warwick, and then for having me on your show. I'm really looking forward to chatting to you.
It's great to have you here, and I'm hopeful that you can teach and educate myself as well as the community about your industry and at a high level talk about what you guys do, why you do it, and how you specifically do it. Before we dive into today's conversation, I want to give you a little bit of context about what a chiropractor actually is. So, I'm going to give you a definition, the meaning, what a chiropractic care represents, the purpose, why they exist, as well as their speciality, what they're experts in. A chiropractor is a licensed healthcare professional who specializes in diagnosing and treating neuromuscular disorders, primarily through manual adjustments and manipulation of the spine. The meaning, what chiropractic care represents, is based on the principle that proper alignment of the body's musculoskeletal structure, especially the spine, enables the body to heal itself without medication or surgery. It emphasizes a natural, hands-on approach to health and wellness. The purpose, why chiropractors exist, is to restore proper spinal alignment, reduce pain, particularly in the back, neck, joints, and headache pain, improve physical function and mobility, support the nervous system for better overall body performance, promotes long-term wellness without the dependency on drugs or invasive procedures. What the chiropractic industry are experts in is spinal adjustments and joint manipulations, posture correction, back and pain relief, headache and migraine management, sports injuries, muscular strains, and workplace-related pain, as well as holistic wellness strategies. Now, here's how this whole interview came about. A few weeks ago, I posted on several well-known local Facebook community groups asking, I'm looking for the best chiropractor in the Gauteng region that you can personally and highly recommend if you had a great experience. Please share your name, what they helped you with, and their contact details. The response was overwhelming, and one of the names that kept coming up over and over again was Dr. Simon Lawson. So naturally, I reached out to him to learn more and invite him on today's podcast. Let me tell you why so many people trust him. Dr. Lawson is not your average chiropractor. He's a registered chiropractor and certified sports physician with over 2 decades of elite experience. He's treated professional athletes across the UK and South Africa, worked at 4 World Games, and is the current chair of the International Sporting Federation's Commission for the International Federation of Sports Chiropractic. He's a former president of both Chiropractic South Africa and the Chiropractic Association of South Africa, a fellow of the Royal College of Chiropractors Sports, and holds a master's in sports and exercise medicine from Nottingham University. He's also the owner of Morningside Chiropractic and Sports Injury Center and part of the Wonders Sports Medicine Center, where we are today, which is a multidisciplinary hub supporting both elite athletes and everyday individuals. And when he's not treating patients, he's running triathlons, conquering the Otter Trail, or cycling the Cape Epic. His passion for performance, wellness, and human potential is clear. So with that introduction, let's get to know Dr. Simon Lawson. And if you're somebody who cares about living pain-free, performing at your best, or simply making smarter decisions about your health and wellness, this podcast is for you. You may want to consider hitting the subscribe button and joining us on the journey to continue to learn from the best in the business right here in our community. So I gave you a little bit of an introduction. Dr. Simon Lawson, welcome to the Community Podcast Show.
Thank you, Warwick, and then for having me on your show. I'm really looking forward to chatting to you.
It's great to have you here, and I'm hopeful that you can teach and educate myself as well as the community about your industry and at a high level talk about what you guys do, why you do it, and how you specifically do it. You can very highly recommend it in the Gauteng region. So I'm delighted to have the opportunity to interview you today and get to know you a little bit better.
It's always lovely to hear that, and it's nice to hear that that your work is appreciated and people acknowledge it. So that thank you, and thanks for reaching out because I think what sort of prompted me to get back in touch with you is because of the misconceptions in our profession, and the miscommunication that happens around our profession with colleagues and healthcare professionals alike. And I think this is an amazing opportunity for us to have a chat. And as you say, educate everyone within this community. But what we actually do as chiropractors and how we can actually help people firstly manage their pain and actually live an active and happy lifestyle and not have to deal with the aches and pains of the day that people think they have to because they're getting older and it's part of aging and it's part of getting on with life. And that's not necessarily always the case.
The research that I've done, your industry is incredibly specialized. Dr. Lawson, take us right back to the beginning. Give us a right back during high school years. Like, why chiropractic? Or even before then, like, I mean, there's so many different disciplines in the medical industry. Yeah, take us on a journey about you and your life story.
I guess my life was always revolved around sport. Grew up in a very sporting family. And certainly up there. Did you grow up in Joburg? Grew up in Joburg, born and bred. Started off on the West Rand. Ended up going to St. John's College. Was there from, we didn't have grade vault in those days, grade 1 all the way through to matric. And then went on to, actually, I got a sports fellowship to go and do my A-levels in the UK. In terms of your chiropractic qualification, and to become a chiropractor, you have to have your master's qualification. But the way they've structured the curriculum now is you could drop out after 3 years and it's not a waste. You get your credits for those 3 years having done a basic science degree in chiropractic.
So to get your master's, that period
is 5 years of lecture material. There's a lot of practical component to it. Halfway through your 5th year, your master's year, you start doing your research component. So it's a master's in which has a part requirement as a research component to it, and which you start halfway through your 5th year, and you would finish in your 6th year. In your 6th year, you're finishing off clinical requirements and doing your internship, which is a Allied Health Professions Council requirement. But they basically factor all of that stuff in your 6th year. So if you've got all your ducks in a row and you're quite diligent about what you do, you could probably graduate and repeat everything 3/4 of the way through your 6th year. Okay. So yeah, it's so those first 2 years, I wouldn't say really binds you towards chiropractic. It's again very much your basic sciences, but from 3rd year onwards, you start being introduced to a lot of more your clinical subjects, your diagnostics, your pathologies, a bit of clinical chiropractic, clinical biomechanics, and that's where you really start to cut your teeth and start to understand a little bit more what chiropractic's all about.
What led you to return to South Africa in 2005, and what inspired you to open the Morningside Chiropractic and Sports Injury Center?
So it's quite interesting because I think my parents and my family had pretty much given up on the fact that I was ever coming back from the UK. I'd been there for 7 years, and I was happy and busy doing all the things I could possibly ever wish to day. And literally was doing my 3 dream jobs. And I'd finished my postgraduate master's in sports and exercise medicine at Nottingham University. And off the back of that, it become very intimately involved with a lot of the sports stuff at the English Institute of Sport, Loughborough University, Nottingham University, Birmingham University. And
What is the total number of years you've actually sat?
structured academia, probably 7.5 years. But I can remember somebody saying to me right at the beginning of my chiropractic journey, saying, if you want to study for the rest of your life, you've chosen the right profession. And I know that that's unique to chiropractic. I think within healthcare or any profession really, like it is this ongoing, education that you need to.
The more you learn, the more you realize. So no,
Absolutely. And things change all the time. But I mean, even now, I don't think there's a day in practice where you're not learning something new or adapting a technique or an approach that's more conversant with clinical guidelines, that's more effective or more specific for the patient. So the learning journey never ends, which is actually, I mean, that's half of the enjoyment. And
this is your 25th year.
this is I've just finished my 25th year in practice. Yeah, great.
And I know you're going a little bit back, but I'm just curious. Although it's, I'm sure a lot of theoretical, but the nature of your profession, which we'll go into shortly, I mean, it's very hands-on. So studying, I mean, is it like 50% knowledge, 50% practical situation, or what percent? Yeah, is that fair to say?
So I think as you kind of bathe through that master's program, um, there is a stronger and stronger practical component. Right from the start, there was a practical component in there. But certainly as you get into your clinical years, so you get introduced a little bit more in third year, but certainly fourth and fifth year, there's a much stronger practical component that comes in. And obviously there's a huge amount of theoretical stuff that you've got to learn as well. But that sort of tapers off or ends at the end of your fifth year. And then the practical stuff just picks up more and more, and a lot more clinically orientated stuff in terms of diagnostics, patient management and treatment management. That becomes more of the focus. It's fascinating because there's a theory out there, there's a 10,000 hour theory, that it takes 10,000 hours for you to become an expert in whatever you do. And often that 10,000 hours theory pertains to sport. And I honestly believe that it pertains to what we do as chiropractors as well. Now, the frightening thing is, I mean, consider how many adjustments or manipulations you would need to do to complete 10,000 hours. That's a hell of adjustments. But I think for me, what is fascinating is chiropractic always talks about the science, the art, and the philosophy. Often our philosophy gets watered down, tapered down, and often got us into political hot waters in years by. But the foundation of our philosophy is very much that if you've got a healthy functioning nervous system, particularly the peripheral nervous system, you've got a healthy functioning body. That's the basis of our philosophy. And I think that holds true. And the science is obviously everything we learn in terms of the theory and what we're actually doing. The science of the body, the science of the nervous system, the science of the neuromuscular skeletal system, the science of what we do in terms of the manipulation, the effect that has physiologically and physically on the body in order to get the results that we get as chiropractors. And then the third part, which is getting back to the hands-on bit, is the art. And honestly, that is the 10,000 hours, should I say, of experience behind the manipulation. So, I mean, as a chiropractor, in essence, we are the specialists in conservative management of the longness of the spine. And in all honesty, like, please believe me, I'm the first to put up my hand. If I need to see an orthopedic surgeon, neurosurgeon, because with orthopod, I've fractured something or I need.
Would you mind running through just at a very basic level, orthopedic, a neurosurgeon yourself, and a physio? Just, yeah.
And it's interesting you bring up that point, because I think there's a lot of misconception or a misunderstanding within the general public on what a specialist is. So often patients will come in and say, do you think I need to go see a specialist? And you say, well, you're consulting with a specialist. No, but I think I need to go see like a neurosurgeon. Absolutely. Neurosurgeon is a specialist in neurosurgery, and they will give you an opinion that 9 times out of 10 is orientated behind them operating on your nervous system or the structures that may influence the nervous system. Similarly, an orthopod is going to operate on joints and bones. That's what they do. That's their area of specialization. I'm not going anywhere near that. I'm super not qualified. I'm not specialized enough to deal with that kind of stuff. Where I am specialized in is the conservative management of whatever you're going to present with. So if you've got back pain, you've got headaches, you've got a sports injury, I'm going to look at you from a very conservative perspective to say, I'm going to try and keep you off the surgeon's harrow at whatever cost I can. There may come a point where there's no debate here. You need to have surgery. Do you know what? You're going to see the orthopod or you're going to go and see the neurosurgeon because they are specialized in that area and they are the best person for that job. We're going to fix you the quickest. And if it doesn't need surgery, or we can try and see with a conservative management, we got to try and delay that process as much as possible. And to be fair, any surgery who's worth his salt will be on that page. Look, at the end of the day, we all got to make a living somehow. And those lines might get smudged at some point of time. But at the end of the day, if I did, or any conservative therapist can try and get you right without you being cut, that has got to be the best option. Once you cut, you can't come back. Whatever's changed, whatever's been repaired, whatever's been replaced is done.
So that being a Bertrand, Doc. Here we go. Talk to me about disc herniations. Is that a very common challenge pain that people see very specifically? I mean, spine disc herniations? Absolutely. Okay, so based further to what you just mentioned about whether surgery is needed or not,
This part of our everyday as a chiropractor is part of our, so it's everyday exposure. So I personally think we very, very much underdiagnose disc injuries. And we base it often on whether there's neurological involvement or not. So is the nerve being compromised? Is the nerve being irritated? Is the nerve being damaged? That's when all of a sudden we get a little bit heated about disc injuries. But I think by and large, most of what we see, it probably has a disc looks involved in it. It never gets diagnosed as a disc injury. Okay, it's often clears up and is treated by manipulating the joints and getting the function back into that area of the spine and restoring normal function, getting the nerve to fire properly, getting the muscles to relax, getting rid of inflammation, and getting normal mechanical function back into that spine. 99% of the time, we're back up and running. Where it starts to get a little bit more shiver.
to pause you there, sorry, Doc. So you're basically saying with disc herniations, that being a chiro is the first place you go.
That's the area we specialize in.
Okay, that's what I wanted to hear.
So where it then gets a little bit more, where you might want to have a little debate, is on the extent of the disc damage. Okay, so where you get a slight disc bulge, you may well have some fairly significant symptoms, but most of the time, with the appropriate treatment, that will settle down and you'll be fine. Most disc injuries, given the time, given the right environment to heal, settle down, and you do not need surgery. Where surgery starts to come into the game is on the extent of that disc herniation of disc. Now, if that disc bulge starts protruding further and starts to compromise the nerve to the point that the nerve could become damaged, now let's start having a conversation about whether you need surgical intervention or not. Okay, and the caveat comes in is if you were to take an MRI scan of literally every patient that walks into your practice.
On that note, walk us through if a new patient comes in, is getting MRI scans, and is that standard procedure?
So MRI scan is our gold standard, and it's only about 84% accurate, and it's still our gold standard, which in this day and age is quite fascinating. And considering all the technology and the advancements that we have, it's fascinating that the MRI is our gold standard and it sits around 84% accuracy. And they are very expensive, particularly in this country. So you can't just send every single patient for an MRI scan. Not that there's even a necessity for that. So a skill that we are taught is to diagnose and to do full clinical assessments on our patients. And a skill that unfortunately with technology is becoming less and less utilized. We're becoming more and more reliant on scans, images, blood tests, any other kind of laboratory tests we can use. We're becoming more reliant on the results from that than we are on our clinical skills, which is quite a serious issue in terms of managing patients going forward, because a lot of the tests that are coming back don't tell the full story. We need to go back to being more reliant on our clinical assessments. But obviously that comes with experience, and that comes with good education right from the start. And a good clinician, a good diagnostician is going to use your scans, your laboratory tests, and that to confirm what they found clinically. Okay, and that is how it should work. So most of the patients who come into a chiropractic office will go through all of those assessments, and generally by the end of that assessment, we've got probably a 90 to 95% chance of being dead right on my diagnosis. Okay, and that diagnosis may well require further imaging or further assessments in terms of blood tests and things like that. But if you've done a good, thorough clinical assessment on that patient, you should be there or thereabouts. And the point I was going to bring up in terms of the MRIs is literally you could MRI every patient who walks into this office. And right from the age of 18 to 100. And I think the statistic is somewhere between high 80s to 95% of those patients will have some kind of disc. Let's call it disc pathology. So they'll have some kind of disc bulge, some kind of derangement in the disc. Most of those patients are completely asymptomatic. And yet, the MRI will demonstrate some kind of disc pathology. So they are there. That without a shadow of a doubt, just about every single one of us have some kind of disc bulge. Is it relevant to your back pain? Is it relevant to your symptoms where we need to delve further? Now, you can look at an MRI scan, put it up there, and there's this disc that absolutely, completely is radiated and is almost obliterating the nerve coming out of one side. You would panic and you say, that needs to be operated on immediately. Otherwise, that nerve is going to be permanently damaged. That patient may have no symptoms whatsoever. Sorry. So, do you operate on that or don't you? They're functional and they don't have any symptoms. So why would you go in there and operate on it? There are a plethora of stories of patients who've been operated on for that reason, and clinically you cannot associate that disc with their symptoms. So we go in and operate on that disc, clean it all up, successful surgery, and yet their symptoms haven't changed. So was that disc even relevant to the conversation to their symptoms? So that's a difficult one. And often that scenario pops up. So we need to find out what we need to do to ascertain 100% that that disc is related to their symptoms. And if there's not that correlation, both clinically and through scans and imaging, that they correlate, then you must not operate in that disc. There's no reason. In the same breath, you could put out another MRI, and you would need the most vivid imagination in the world to see the tiniest disc bulge, and yet they have florid symptoms. And the clinical findings and the florid symptoms pertain to that disc. Now what you tell me, doc. So from a conservative therapy perspective, we are not going to operate on that disc because there's no indicator. But we need to treat that disc with kid gloves, give that disc the environment and the support that it needs to heal.
Do you have an example, a practical example of one of your clients that came in that almost went for surgery?
There's a number of different stories. I mean, honestly, some of these stories are what keeps you going as a chiropractor. I mean, those Yahoo moments. Probably two that really stand out the most one was when I was still in the UK. A lady in her early 50s was brought in to see me in a wheelchair. She'd been in a wheelchair for 30 years. As a 20-year-old, she slipped and fell, and she injured her back, and she had horrible symptoms down her legs. She went to go and see the orthopod, and the orthopod said, absolutely, we need to operate, and otherwise you will be in a wheelchair for the rest of your life. Anyway, she had the operation. It didn't change her symptoms at all, and she was put in a wheelchair. She had spent 30 years of her life in a wheelchair and being wheeled around by her husband, and she got used. That was life. It wasn't great, but that was life. Anyway, she had been considerably uncomfortable for a while, and somebody had suggested, why don't you go see a chiropractor? So her husband wheeled her in, great pains to lift her out of the wheelchair, get her on the bed, checked her out. There was nothing grossly obvious or any major red flags that were showing up, other than 1-2 nerve roots that seemingly weren't functioning as well as they should have, which we picked up through the assessment. So based on that, I treated her with what we found clinically. And not under special treatments than any other patient has ever received in terms of what we were doing chiropractically. Treated the lady, said, right, I think we're done. So she then sat up, got off the bed, and walked towards the wheelchair, and didn't really think at the time too much about it. Her husband didn't really think too much about it. As she got to her wheelchair to sit down, she realized what she had just done. And her husband's jaw dropped. I think my jaw must have bounced off the floor, and she just welled up with tears. Now, the chances are that breakdown in the function of those nerves happened when she fell when she was 22. And just like if you were to pinch a hose pipe and the water doesn't come out as effectively or as initially, that's essentially what was happening to these nerves for 30 years. All we did was remove the clamp or the restriction on the hose pipe and allow that information to come back through again. And all of a sudden, this woman's walking. I mean, that is a fairly cathartic moment for anybody. And I'm not saying, please don't get me wrong, that doesn't happen every day in my practice. But those are the kind of things that actually make you understand and realize that, holy smoke, this actually works. And please, I'd love to claim that for me. But I didn't do anything that I wasn't taught as a chiropractor. I literally apply what I've been taught as a chiropractor. It's literally changed this woman's life. The other story that I'd like to share with you, which to this day I find absolutely fascinating, and again, it's one of those standout moments, and where I can give you a whole lot of stories of people who come in here crawling or in absolute pain, you adjust them when they walk out, and they think you're the most amazing person on the planet. And I think over time you take those sort of stories for granted. That happens more frequently, but these stories are the ones that really stand out. There's a lady I started treating just after I got back from the UK. And she was, I think at the time, probably early 20s, maybe mid-20s, 22, 24-ish. And very driven, go-getter lady. She had her own beauty therapy practice. And obviously with beauty therapy, was in awkward positions for long periods of time, all through the day. She was working all the hours that God sent. And inevitably ended up with back pain. So she came to me for this lower back pain, treated her, responded beautifully well within a trick or two, and she just back. We didn't see her for months on it. She come back, same sort of story, and treat her once or twice, just go and see her again. And again, came back to you 4 months later. This time was a little bit more than previous times. Similar presentation. She did her again, needed a third treatment, and then she goes, well, she would. But 3 months later, she comes back. Same sort of presentation, again a little bit worse, but okay. Treated her again, this time needed a fourth treatment to get her right. Off she went. Came back 2 months later. Now I'm like, Diggy, I don't like this guy one. You shouldn't be dropping off. Other than the fact that maybe we should be continuing this treatment a little bit more consistently and not allowing you to get into this trouble, because obviously work, load, positions, whatever, it's causing me to get into trouble. But that shouldn't be the case. You should be able to maintain what you're doing for long periods of time. There was definitely this underlying disc kind of presentation was coming in. It wasn't big red flag stuff, but each time she was coming in, there was more of a disky involvement coming into the presentation. So I said to her, listen, we really do need to be a bit more consistent in our treatment going forward. Otherwise, this pattern that we develop is not looking great. Oh, absolutely. She's on board. Cool. Treated her. This time probably needed a fifth or sixth treatment to get her going. I said to her, listen, I'm not happy. We should maybe start to look at either send you for an MRI or at least send you off to the neurosurgeon for another opinion. Absolutely. I haven't got time for that. I'm in busy practice. Cool. Off she went. 6 weeks later, she was back. I said to her, okay, I don't like this. So at the time, I contacted a neurosurgeon I work quite closely with at Lexfield Clinic. I said to him, listen, I'm sending this lady.
So you work closely with neurosurgeons.
Yeah, I would interrupt. No, absolutely. But I mean, there are those presentations that you either know are going to be borderline from a conservative therapy perspective, or you know from a conservative therapy perspective, this is actually a surgical case. So I contacted him and said, listen, I'm seeing this lady through, and I think I need you to have a little look. She's an MRI. Have a little look. Let me know what you think. So further background to the story was that she'd obviously got married in the interim and they wanted kids. So every time they felt pregnant, she would get a certain way down the line and then she'd miscarry and try everything. Gynae was obviously quite concerned because there'd been 3 or 4 incidents where she had miscarried and she just wasn't able to hold on to the embryo. And it got to the point where the gynae actually said to her, listen, you're out. For the next year, I do not want you even trying. Your body needs a chance to recover. You've had 5 or 6 miscarriages now. This is not good. We need to give your system a chance to sit down, and then we'll review. Maybe we need to do IVF. Maybe we need to look at other things, but you actually need to give your body half a chance. So you are not a full pregnant. So, I mean, there was an interesting kind of addition to the story of what was going on. Anyway, send her off to the neurosurgeon at Lexfield, and he checks her out, sends you straight away for an MR. I have a missed call from him at about 12:30. It was a Friday afternoon. I was busy with a patient, so I got to try and phone her back. Said, Doc, what's the story? He says, listen here. I had not seen this bowel this big since I can't remember where. He said, we need to decompress that very immediately. I'm operating on it this afternoon. I said, Doc, if you have to cause up, the indications have been there for a while. Put her under, up went well, great. Pain disappeared straight after the op. And she had about 6 weeks recovery. And she came back to see me, said, how things going now? I've been told to come back and see you because part of the process of healing and doing the rehab. And she looked great. She was awesome. So I said to her, listen, we need to follow this rehab program. And I think you'll be good. I think going forward, you'll be great. She was nuts and true to form. And I think I saw her twice and she got too busy. Life got busy. Practice got busy. And probably didn't see her for probably, I think it was 6 or 8 months. Anyway, she phoned, she came in from lower part and I said, what's going on? She goes, no, I'm getting all the time to my lower back. And I'm pregnant. I'm like, well, I said, was that why? She said, well, I don't know, but I've been feeling good. So I think we should be fine. So just a bit, she was great. She was fun. The next time I saw her was after she gave birth to her first child. And she, as far as I know, she's now had 4 children. True. And basically dialing it back, the reason why she kept miscarrying was because of vectors, because there's some clinical disc, but as she was starting to go through pregnancy, her body was more than aware of the fact that the chances of her carrying it to term to live down. And she just kept dropping and having a miscarriage. The minute we sorted that discount, she's getting, oh, there's nobody. And the regular chips a day, that's what we should have numbers. And an amazing story. And I love this story.
I mean, we're sitting at the Wanderers Sports Centre here. What are the specific sports that you help more than others? Are there specific sports that you found that pick up more injuries? And can you give perhaps those specific sport athletes some tips and things of what to avoid? And yeah, just like bring it more back to you. I mean, you're very heavily into sports, chiropractic. So yeah, you give us a rundown.
We're very fortunate in that chiropractic itself resonates and lends itself to sports and sports injuries. And in the raw essence of what we do as chiropractors, literally we are restoring mechanics and restoring function so that you can get back out there and perform as a sporter. And I think in terms of sports, I mean, obviously your contact sports generally are more prevalent in your office for obvious reasons. But but there are sort of quirky sports where we definitely pick up more back injuries. Your gymnasts, your dancers, being here at the Wonders and Sports Medicine Centre at the cricket stadium. This is one of your offices. Yeah, there are lots and lots of cricketers, and particular bowlers, particular fast bowlers. And all is significant still for you. Absolutely. And like I resonate with that, because it's a very common injury, which these days managed is not a problem. And, we used to wait until everything blew up in the past. And then now you've got to repair, you've got to fix the injury, and then slowly get them back into bowling. And, these days we can pick that up through screening, that we can pick it up much earlier, much quicker. We can manage them through and make sure that they don't get to a point where they get injured. But, the same regards, fast bowlers are notoriously prone to these kind of injuries. And tennis players also, again, probably, you pick up a lot of that stuff that's screening, but if they got big serves, those are kind of the guys who want to pick up those kind of injuries in their low backs. Um, the one that's quite interesting is obviously everybody smiles when you mention paddle, because I think paddle is now like the new CrossFit. The fascinating thing is, yes, that there are the repeated strain injuries from playing a sport, but the injury profile behind paddle is fascinating in terms of the fact that the majority of injuries are quite severe injuries. And I guess it's because you are dealing with a population who probably previously were quite sedentary and are now jumping into paddle, get hooked in, so love it, which is great. Got to have people out there moving and being active. But playing on a synthetic surface and being more active than they maybe have been used to in the past, they are more prone to more severe injuries. So you're seeing things like collarbone injuries, ACL injuries in the knee, and quite severe injuries from hitting your blast, shoulder injuries, and sprained ankles, things like that, and often resulting in some kind of surgical intervention. So as much as we do see the repeated strain injuries that come in, which would be part of our day-to-day stuff, I wouldn't say we're exponentially seeing more paddle for padders. And those nasty injuries are going to the surgeons, and then from the surgeons going for rehab, either the physio or the biokineticist. So that's an interesting.
And with regards to his injuries, and perhaps to give a tip to the sports men and women out there, the importance of like warming up. And do you think a lot of injuries would be prevented with, like warming up? And I was hoping to have one or two other things just to suggest, like, drink enough water. Like,
So all of that stuff is critically important. And anything significant
that yeah, us.
So, I mean, generally, your elite level guys have got a lot of knowledge on that, and we can get into more specific things. But I guess more your weekend warriors and your guys who still like to play relatively competitive sport, or at least are active on the weekends and play their sports. And those are the guys who maybe need a bit of advice in terms of making sure you stay hydrated, making sure that you do have some kind of nutrition to keep your system fueled up and going. And general rules and general concepts, always a good idea to warm up before your activity. What that means is getting your heart rate up to a level to get a little bit warm, get a little bit of a light sweat going on, and getting your blood pumping around your body. And to add into that, a couple of general stretches, but ideally the muscle groups that you're going to be using, just to get a little bit of a heads up to say, hey, we're about to use you. That helps without a shadow of a doubt. And I don't think you need to get into any kind of high level and high performance kind of stretches and warm up routines. That general approach, so jogging for 10 minutes, doing some light stretching specifically on the muscle groups that you're going to be using, would by and large be enough to get you out of most of your sports injury troubles. Probably more pertinent and more important is spending a little bit of time afterwards, cooling down, having a bit of a longer stretch. Why is that important? So it helps recover quicker. And your recovery then allows you to perform better going forward. So if you can recover quicker from your previous exercise bound, you're less likely to get injured going forward.
So also, so just as important as a warm up in the beginning of one's exercise, you're saying the significance is just as important at the end. Because at the end, you want to rush, go to work, whatever, you don't have time for. So we're talking like a 5 minute just overall stretch.
So you'll get away with that as a warm up. But ideally, you should be spending 20 minutes, half an hour after your activity, holding down, stretching properly, giving your body a chance to recover. Now, we all know the lesson. Not gonna. Most guys arrive just in time for their game, straight into the game, and then you're straight off the pitch, you maybe having a drink with your teammates, and then you're shooting off to do whatever else. So we don't do either thing.
I guess my first question is, do you do it?
So yes, probably not diligently, but it's certainly a warm up. I certainly may try a warm up before I start. I'm probably not as diligent doing the 20-30 minutes afterwards, but I will definitely do a stretch and a couple of recovery things post-event, which gives me half a chance the next time I play of not being overly stiff or being tight, that I'm not going to risk having an injury the next time around.
How do you manage you've seen back-to-back clients, working 10, 12 hours a day, hectic. How do you manage the stress from what you're doing to your physical, and
You're a family man yourself. Do you exercise daily? Do you cycle?
And I think the nature of our profession is that we actually do need to be fairly fit and healthy. I also think, if particularly as a sports chiropractor, if you're not fit and healthy and purporting all of these health measures that you want your patients to follow, how do you expect them to listen to you if you are living by what you talk about? So I've had a varied career. Hockey was always my biggest passion and love, and I played hockey for many years. I've interestingly just gone back to it after 13 years, which has been an interesting process. But most ball sports I played. At some point there was a shift towards fairly serious mountain biking and triathlon. I was fairly competitive in triathlon for quite a while. Running has always been a big thing in our family. My dad did 10 or 11 comrades. And
So I dad's done 20.
grew up on the side of the road. So, I was always sort of exposed to that kind of stuff. So, I've done some amazing events, done the Cape Epic, done the Otter, done they've been amazing things. You learn a lot about yourself and your body by doing those sort of things. And I guess taking a lot of those lessons and I feed those back into my patients. They give a lot of advice and a lot of sort of good experiential knowledge back to my patients in terms of that sort of stuff. These days, I probably, on a bad week, probably train 4 times a week. So yeah, I'm still active and I still like to be relatively competitive in a lot of the stuff I do. Time is an issue. I work in an environment where time is everything. So to be able to see all those patients and time for yourself, and I need that exercise to keep my head in the right space.
When do you train? In the morning or afterward?
So generally 4:30 in the morning.
So right through winter.
Yeah, it's a challenge, but it's the discipline. Yeah, it is a discipline, and it helps me keep my head in the right space. And then obviously also time for family, time for your mates, and all those kind of things. It's pressurized time, right? But I love what I do, and I think that's what motivates me, and it keeps me going. Oh, sure. And that one thing I've said this to numerous students over time, mentoring students and lecturing as well. And the beauty of chiropractic is if you get depressed or upset about what you do, you only really got yourself to blame. There is so much diversity within our profession, and you can have a special interest in pediatrics, in sport, in geriatrics, and you can even go into things like radiology. And so you can really specialize your focus, but you can work for yourself. You can have a multidiscipline practice. You can work within a multidiscipline practice. You can work for a sports team. You could work for a corporate. You could work on one of these cruise ships. I mean, the options on where to work and how to work are are huge. And in that regard, I'm fortunate. I don't see myself having to get up every morning and go to work. I don't see it as a job. I really enjoy the exposure with my patients, and I get a lot of energy and passion out of making a difference to people's lives.
So you spend a lot of time sitting up most corporate jobs from an expert like yourself, knowing the spine and your body. And are there certain ways that you perhaps sit or stretch during the day, or are there certain things that you do that's to help you a little bit, knowing at the high end about
So I'm fortunate, and then most of the day I'm on my feet and I'm moving around. So I don't get exposed to those postural ills. But, they're not postural habits, I guess, you form within practice. Like you always treat a patient from the same side of the treatment table, or you'll do a certain technique in a certain position at a time. And one of the challenges as a practitioner is to make sure you keep changing it up. Force yourself to go down the side of the table. Force yourself to do that technique in a different position. And those are fairly particular things to us as chiropractors in the profession you're working. In terms of the corporate environment, it's actually fascinating how it's evolved, because certainly pre-COVID, there was very structured guidelines in terms of what chair do you need, what position, what angle does that chair need to be in, what should your desk look like, how do you position your screens, where should your mouse be, what sort of keyboard should you have, and all of that kind of stuff. And there's no doubt the particulars behind that do play a role in terms of the postural modes that your body is exposed to. So yes, it does make a difference on what level your screen is at. If you've got multiple screens, having one there and one there is not ideal. So having them within your field of vision helps reduce a lot of the postural stresses and strains. Are you chasing the mouse around the table all day, every day? Or can you keep your arms next to your side and just move your hand with all that? Those all had postural bearing. But what's quite interesting post-COVID, and obviously with people moving home and working in different environments, we now don't have this rigid, structured corporate scenario. And what's come out is the bottom line is, as long as you don't overload the postural element on tissue, you'll probably be okay. You don't do away with it.
where's that overloaded? I mean, I'm hoping for like some tips, like, I don't know, every 20 minutes you start to do this stretch, or is there any like little tips you can give that?
This is certainly not conducive to work, but a season alarm or have some kind of reminder, somewhere between 40 minutes and 60 minutes. Let's call it 50 minutes. It goes off every 50 minutes to remind you to move. Now, the simplest version of that, get up out of your chair, walk around the chair, touch your toes, move around a little bit, and sit down.
For feet together, bending over, touch your toes.
Yeah. Or just move. Go get a puff. Go to the toilet. Go to the break on the lots of sissy things. I get it. Like once you're engrossed in some of your things, you go, 50 minutes space and I'm on meat. But you need that discipline of breaking that monotony. If you can take that further and you've got the space within your workstation, move from a chair onto an exercise ball, or kneel, or stand, or take your laptop to a bar counter, or heaven forbid, go and sit on a couch for half an hour. But as long as you're moving around and you're loading different tissue, and you're not loading the same tissue consistently for hours and hours and hours on bed, you're going to be okay. And there was, I think it was probably the late 80s, maybe into the early 90s, there were these kneeling chairs, which were amazing. You would sort of sit your bum on the one angle, bend your knees and rest your knees on another cushion underneath. And they were fantastic. There was nothing behind you, that you would sit upright and you would work away on this kneeling chair. Everybody loved it. Back pain went out the window. Everybody was excited and happy about it. But within a year, guys started to get knee problems. So now they're all off to an orthopod for knee surgery. So it doesn't matter what position you're in. If you're in that position for long enough, you're going to start getting postural issues. And that goes to standing desks as well. They're the rage moment. Everybody wants a standing desk. They're brilliant. As long as they're adjustable height-wise, They are absolutely brilliant. So you can sit there, you can then move it up, and you can stand. But as long as you're changing that postural position, you're going to be good.
Doc, tell me, with regards to, the cost of medical aids, medication, etc., when you talk back pain, neck pain, have there been perhaps people that have come to see you that had for months, years, taking heavy painkillers, and then with you treating them, whether it's a day, a week, a month, or a period of time, that they no longer take medication, whether it's back or inflammations or whatever, things like that. Okay.
So, look, we live in a society where people want personal gratification. So, I'm in pain, get rid of the pain for me. And unfortunately, that's why often we default to anti-inflammatories and painkillers. Because 9 times out of 10, it'll either take the edge off it or it'll take the pain away. The bottom line is, it's a bit like the alarm going off at home in the middle of the night. And all you do is just switch off the alarm and go back to bed. Like, you haven't dealt with the issue.
Is what big causes the pain, the neck pain, the what?
So generally, it's a simple question.
It should have started with it.
So the pains your body's alarm system say, hey, yeah, something's out. Oh, we got a problem here. I actually need you to pay a bit of attention. And again, because of the environments we live in and the lifestyles that we lead, we don't have time for that. So we take painkiller, we take anti-inflammatory, we switch it off, and we carry on. It comes back. So then we take 2. It comes back. Then we take even more, or we take something stronger, and it keeps coming back. It's the alarm telling you each time, listen, there's a problem. No, there's not. Listen, there's a light. And we just keep ignoring it. And somebody goes, I've tried. I've given you enough warning. I'm not going to take the rag out from under the feet. And then we're done. Now we're crawling. We can't get out of bed. We can't concentrate. About blinding headaches, or it's your body's way of saying, you're not listening to. And there's a problem here that you're not dealing with. So don't ignore pain. The pain is there for a reason, to say something's not right here. I get it. We all come from the same background. We all I don't have time to deal with this right now. And if I tense something, it goes away. I'm happy I can continue. Fine, for now, you'll get away with that. But deal with it. Don't ignore the pain.
When we talk, I know a lot of people that suffer from very bad knee cranes, headaches, etc. Like, as you said, the easy, a tablet situation. But are you saying it's actually a lot of patients come and see you because of me? I know in the beginning, when I introduced the little introduction, one of the things that she specializes is neck pain specifically. So, yeah, take us through it. So, like, what
with most of my patients, I try and give an analogy where your body has an amazing capacity to cope with everything that we throw at it every single day. So whether that's work stress, home stress, things that we eat that might not necessarily agree with our body, things that we drink that might not necessarily agree with our body, and things that we're exposed to in terms of your environment, carpet fibers, curtains, the air. I mean, all of these things have an impact on our body all the time. And we're blissfully unaware our bodies cope with it. But if it's enough of a load and the irritation on our system, we lose that capacity to cope. And when we get to a stage where we now have completely lost it, we go through the threshold where the alarm system goes. Okay. Generally, as long as we remove that aggravating factor, we'll drop back below that threshold and we feel fine again. But often, if that's the case, it doesn't take much to throw us back through the threshold and the alarm system goes off again. So often what I'll say to patients, there are a myriad of different ways you can deal with this. But our job is to try and recreate as much of this reserve volume as we possibly can. So when you do get exposed to pollens and dust and stresses and strains in your day, you're not rocketing straight through this threshold all the time. You've got a bit of capacity to cope. Now, whether you decide to go and speak to a psychologist, or you decide to take medication, or you go see a chiropractor or physio, or you do yoga, or you do Reiki, or whatever it is you find helps you recreate some of that load underneath that threshold, you will stay out of that pain zone. And from a chiropractic perspective, we look at it very much from a neuromusculoskeletal perspective, but there's a lot of mechanical stuff there that we can work on to help recreate that. And again, the stuff that we're exposed to on a daily basis, most organisms on this planet would never cope with that kind of stress that we're under, and yet we do so well. So you got to know when that pain kicks in, your body really has tried everything it possibly can to try and get you through the day. And the only reason that alarm systems go off is it needs some help. So address it, don't ignore it. And painkillers and anti-inflammatories or drug medication doesn't solve the problem. It just helps you get back below the threshold. The problem still exists.
So somebody with, in the last week, month, an hour ago, has a client come in with, I suppose specifically we're talking about head aches, head pain, like you've treated them and within the next day, or you've had great feedback from adjusting their neck. I suppose that's what I'm trying to understand.
And I had a patient this morning who came in with what he described as severe neck pain, and a lot of grinding, clicking, popping, everything that goes on with a little bit of wear and tear and degeneration of the neck. That in itself wasn't painful, but he described this unbelievable, intense, severe neck pain, which then often radiates into a headache on that left-hand side. And whilst I was treating him, this didn't really come up with the case history, but whilst I was treating him, he said, "Doc, you don't understand the level of this pain. Like, I'm not the type of person who starts looking at buildings and going, and starts saying to myself, is that building high enough?" He says, I'm not that, I don't want to go down that road, but I'm starting to think about things in my life that's scary in terms of not wanting to be here anymore. Now that frightens me. I do. So I checked him out, and there was a lot going on in terms of the mechanics of his neck, and the headache that he described would have been diagnosed as subchogenic headache, meaning that the headache was emanating from structures within the neck, the upper back and the neck, which were then creating the headache scenario. And there was a long history of lower back pain and lower back ache that he's relatively managed for a number of years, but that was integral into what was happening further up. So we ended up treating his lower back as well, and thankfully we got a really good release in terms of what was happening in his neck. He got off the table and looked at me. All of a sudden, there was light and energy in his face and his eyes, and he says, "Doc, that is the first time in 2 years that I have neck pain in my head."
You see, that's just what fascinates me about your industry is the stories like that. The lady in the wheelchair, yes, but there's certain adjustments or certain things that, knowing the body, spine body connection the way you do, it's incredible. That's, there's, so tell us more.
So you often say this in the chiropractic world, is that, there's nothing more powerful on this planet than an appropriate adjustment at the right time, the right direction, to the right joint. There's not a drug, there's no surgical intervention, there is nothing in this planet that has that kind of powerful effect on the human body. And it can literally remove a headache in the heartbeat. It can restore function and remove chronic pain syndromes. It is that powerful. And please don't get me wrong. I'm not saying that every single patient in here, we're going to give one adjustment to and their problems are resolved. But there's so many adjustment has the ability to have that kind of effect on the body.
Have you found more adjustments are more significant than others? Top 5 or?
No, I think so the secret in that is your assessment, identifying the source of the problem and the primary issue. The more accurate you are with that, and the more accurate you are with your manipulation and your adjustment, gives you the better result. So, often if you go and look at research and certainly research that might knock the effects of manipulation or adjustments generally, most of that research is done on general manipulation. Now, there are osteopaths who manipulate. There are physios who manipulate, then orthopedic manipulative therapy and postgraduate courses. Rightly or wrongly, there are biokineticists who manipulate, there are massage therapists who manipulate, there are Thai massage therapists who manipulate. So anybody who's clicking and popping that is a manipulation, or considered to be a manipulation of the joint. That is not a chiropractic adjustment. It is way too general, it is not specific enough, and is not targeted at the source of your problem.
Sure.
And that is where one misconception manipulation gets bad rap, because that's the consideration is that, if you clipped or popped, you'll be manipulated. One of the biggest mistakes you can make is having a general manipulation. If you've got any areas of instability and you generally go and manipulate those areas, you can cause some serious, serious damage to that patient. And unless you are that skilled in the mechanics, the biomechanics of the spine, the likelihood of you picking up that area of instability when you're just cracking and crunching bones is highly unlikely, and you will cause serious damage.
Because there's so many neurons connected to the spine, connected to your brain. I mean, a little bit earlier we spoke, and I hope we can do a little bit of a deep dive on the misconceptions in the chiropractic industry. What are they, Doc?
Where should we start? Look, I think traditionally, and probably historically, and what's, I think probably more from a professional perspective, rather than the lay person, is this idea of a root and click doctor. So you go see a chiropractor, you're in the nuts and tubers, and off you go. Seemingly, sometimes it worked, sometimes it didn't. Some people ended up having surgery anyway, and the chiropractor possibly made it worse. So that misconception of root and click doctor, and again, comes back to what we were talking about, that general manipulation. It's not about, did you get the click out of it? A lot of patients come here wanting the click, and they associate the click with a successful treatment.
Is it really there? There's something significant.
So it's associated. So if you hear a click, something's released, something's moved. Okay, I'm better. The ultimate effect on the manipulation or the chiropractic adjustment is the effect we have on the neurological receptors around the joint. Around every joint in your body, there's a capsule, which is richly, richly innervated by neurological receptors. It is the impact we have on those neurological receptors that makes the physiological change to that area. Everybody likes to hear it, because then we know something's moved or something's, that is not the be all and end all of the treatment. Yes, it does help. There's psychological factors that go with it. Certainly from a mechanical perspective, when you've released that joint and nearly thick, you can go back and there's a palpable change in the range of movements in that joint, which is great. What I'm saying is it doesn't necessarily have to click for you to have had the effect that it should be getting from the manipulation. So that's the one thing. Even now today, I've got healthcare medical colleagues who say, listen, I don't know what to do, but go and speak harder. I'm sure he'll fix you. Now, there's an issue there, because one, I haven't done my job, because I haven't even spoken to our colleagues and explained to them exactly what I do as a chiropractor. And two, they haven't just gone far enough to understand what a chiropractor does, and yet they're quite happy to send the patient to us.
So it's not constantly known in the healthcare profession what chiros do.
Not often. And unfortunately, a lot of the healthcare professionals out there,
No wonder that the community is a little bit confused on this other.
and the one I find fascinating is the response that you go to chiropractic. Are you crazy? Those people could cheat. They could break your neck, and they could rupture your disc. And, like, you can't just go clipping and popping the spine. No, like, with due respect, we've studied for 6 years. We've specialized in this. This is what we do. We don't click and pop spines. And there are very, very few stories, cases of patients that have had real adverse effects to chiropractic manipulation. And 9 times out of 10, and it's usually neck related. 9 times out of 10, those adverse reactions to a chiropractic manipulation were more than likely happening before the chiropractor even got there. And even having done the chiropractic assessment and neurological and physical assessment, the red flags didn't show. And that can happen. So one of the biggest things is what they call a cerebrovascular accident, which in all essence is a stroke. You've got more chance of getting a stroke going to the hairdresser and having your hair washed and basic than you have from chiropractic adjustment. And yet then the analogy or the assumption is, don't you dare go anywhere near a chiropractor because they will cause you to have a stroke or break your neck. That's not true. There are statistics, because if it never happened, there would never be statistics. But the risk of any kind of major adverse effects to chiropractic manipulation is 1 in 300 million adjustments. Now, to put that into context, if you were to take an average, healthy, active individual between the ages of 18 and 60, 70 or 80, and you were to have a one-off exposure to a non-steroidal anti-inflammatory, which is your typical Voltaren, Cataplan, whatever you might take before you go back off for the Saturday morning or before you go run a marathon, or as a headache from the night before, your one-off exposure to an anti-inflammatory leading to a risk of a cerebrovascular accident is 1 in 60,000. And yet, people are quite happy to take an anti-inflammatory, one-off anti-inflammatory in a woman, and yet you won't go to chiropractor, but your risk is 1 in 300 odd million adjustments. So that puts it into reason, and that's a myth and a misconception that we really need to put to bed. And please believe me, the way that we are educated, we are taught for 6 years how not to break legs, how not to put people in hospital, how not to cause further damage to discs and to areas that have been injured. And I think that's really important, that misconception needs to be addressed and needs to be put to bed. I always find it fascinating, and funny enough, patients will ask you this question as they're lying down on the bed, and as you're about to manipulate the neck, they'll go, is it easy to break someone's neck?
Is it?
What? To break? And I mean, the answer is it's incredibly easy to break someone's neck. I mean, I always say that Bruce Lee and the ninjas did nothing for our perfection. In fact, really upset our perfection, because it really is easy to break someone's neck. If you know what you did, if you get the right position, the right angle, with the right speed, it is the easiest thing in the world to make someone say. But as I say, thankfully, we are taught for 6 years how not to do this. And there's no doubt that the best results that you get from a particular neck manipulation or adjusting is speed related. Speed is the key to the adjustment. And you know, if you're too slow, if you're too forceful, you are going to bend the patient. But again, that is what we're educated at. That is what we're taught. That's like 10,000 hours we were talking about earlier. You know, that's where the art of that manipulation comes in.
And I love the way that it is, I mean, to adjust somebody's body, knowing the spine, how
Neuromuscular connection, I mean, it's an art form. I mean, you have artists the Picassos that, you know what I mean? Like it's a skilled art form. So yeah. So you were saying about misconceptions. You listed 3. You can?
So another common misconception is kicking my joints give me arthritis. Oh, now interesting. Now that dates back to an old wives' tale, and particularly pertains to kicking knuckles. So it's not true. It's a myth. There's an element of truthfulness. Okay, so around every joint in the body, there's a capsule. Inside the capsule, there's fluid which nourishes the cartilage and keeps the joint healthy. But in fact, all the joints have a little gas bubble that sits inside there, which creates pressure in the joint and keeps it all together. Some joints have bony structural margins, which give it a lot more support. Other joints rely very heavy on ligaments and the joint capsule to give them more support, which is where the knuckle thing comes in. There's not a lot of bony support to either side of that knuckle joint. So it relies very heavy on the capsule and the ligaments either side. Okay? So, be that as it may, if you were to create an impulse across that joint, you will release that laspa, which is the Keppel pot that you get. It releases the pressure in the joint and in principle allows you to put the joint back in line or back on track. It releases enough pressure for you to do that. So it should be fit. So it is a good thing, particularly if that joint is restricted or it doesn't have its full range of movement. Okay. The science shows us that it takes about 20 minutes for that gas bubble to reform again. So as it dissipates, it splinters into millions of tiny bubbles. You get that cavitation or that kickle pop that you get. and then it comes back together. It takes 20 minutes to do that. In that time, it reinstates the pressure back into the joint. So the principle behind the manipulation is you get the cavitation, sputtering all those bubbles. 20 minutes later, that bubble comes back together, reinstates the pressure in the joint, but now the joint is in a better functional position in terms of its mechanics. Okay? In principle, that should be good. In theory, or in practice, it takes probably 2 or 3 adjustments for it to stick in that position. There's muscle tension, there's tissue tension, everything like that the body's got used to, or the joints got used to, which it needs to overcome. And it takes a treatment or two for it to get over that. But that in essence is the click or pop behind it. Now, what ends up happening with the knuckles is that it becomes a hurt. So people are now clicking their joints 2 or 3, 4 or 5, 6 or 7, 10 or 30 times a day. And obviously, the more you do it, the more you stretch the capsule, the more you stretch the right. Those are your protective mechanisms. Now, if you stretch them, when you need those to kick in to protect the joint, they kick in a lot later. You go a lot further before they give you your protection. And the luck of it is you then going to damage the surface of the joint. The minute you damage the surface of the joint, the wear and tear process starts, which is the osteoarthritis, the wear and tear, degeneration that people talk about in joints. Once that process is started, it's going to continue. Doesn't matter what you or I do. The better the function of the joint, the slower the rate of that degeneration. If you leave that joint blocked up or jammed up and it doesn't work that well, and you don't stimulate the fluid in the joint to keep it healthy, the faster that rate of degeneration. Okay. So the looser that joint is, the more impact it takes, the more degeneration it's in there, the quicker the degeneration comes. Now with some, you've got arthritis, osteoarthritis, wear and tear, degeneration. So the element of truth is if you do it regularly enough, yes, you are going to get osteoarthritis.
Like, is he like doing anything, Karashima? Yeah.
Now, it was a random study, probably 15 years ago, that somehow they worked out what the safe number of manipulations or adjustments to a joint would be over a given period of time. And randomly, they came up with a number of 52 or 53, I think it was, adjustments to the same joint over a year's period. Okay. So to work that out, that's one adjustment a week. Now, for anything that you're coming to a chiropractor for, if you're getting a one adjustment a week for a whole year, on a same joint, there's something horribly wrong with that. Either the chiropractor is not doing his job, or that you've got another issue going on there. But to keep manipulating the same joint, and it's still manipulable every week for a year.
Okay, that's interesting. What are the top 5 neuromuscular calisthenics? Like, what is that?
So I would say our bread and butter is neck and back. As simple as that. Okay, and most of the time it's mechanical in origin. If you have a look at our country, very specifically, and this kind of ties in the video with what you're talking about, medical aids and our healthcare system. Probably 80% of our population, more, are manual laborers. And the most common situation in terms of manual labor is low back pain. And the majority of those people in our population do not have access to chiropractic care. In fact, most of it often, they don't even have access to any kind of musculoskeletal care, full stop. What ends up happening is that their back pain is bad enough, they go to hospital. Chances are they might get an x-ray, which doesn't really show much, but a wear and tear, maybe a little bit of degeneration, but they get given pain for this. If your pain is better, come back and see me in the high wall. 6 weeks later, they come back, their back pain is no better. They get strong painkillers or medication, and if there's a physio department, they might get referred to that. The chances of them seeing their physio within the public health scenario is probably not great. But now you're talking a process that is going on for months and months, if not years and years. In the meantime, they're all for work. 9 times out of 10, that individual is the breadwinner for a huge family that are reliant on that income. That is a common issue in our country. Now, within what chiropractic can offer the public health sector, is that's what we do. Mechanical low back pain is our bread and butter. Let's get them in, assess them, treat them for their low back, off they go, they're back to work. And the stats are 89% of the world's population suffer with low back pain and indemnity time. So it's a very real issue. Go through common me that chiropractors can treat literally as bread and butter every single day. Now, the knock-on effect to that, to the medical aids, to national health is massive. It's huge. So I would say that's probably number one. In terms of your some more corporate population or stuck in front of computers, there's the postural element we discussed earlier. A lot of neck pain, upper back neck pain, largely posture related. The feed on from that, now we start to look at headache scenarios. And certainly cervicogenic headaches are a big part of what we would treat on a day-to-day basis. On top of that, got arm pain, leg pain, often associated back to issues coming from the lower back or the neck, where a nerve has now got irritated, and now you've got some kind of what they would call a radicular symptomatology. In other words, the nerve is irritated, and that is now causing referral pain either down the arm or down the leg, which may also lead to dysfunction. So the inability to use certain muscles that are innervated by those nerves, and ongoing pain, can't get out of that pain syndrome. Those are probably the biggest things. I would say low back pain and neck pain, headaches, and then referred pains either down the arms or down the legs.
A community member posted this as a comment, which I thought really, and it's no affiliation to you, but in the industry, is that this individual went to a chiropractor and once, and obviously had a bad experience, whatever it may be, and said, "No, chiropractors are bad. You must go to a physio." So I guess that opens the door for lots of conversations here. Like, how do you handle if somebody comes and sees you? I'm sure clients walking out with a smile, but then the clients that walk out with a frown. Now, my question is, with a frown, is it I'm not quite sure what question I want to ask, but I think you understand the concept of. So I often find, in other words, they had a bad experience, and then this connotation that chiros are bad.
So I think on that scenario, a lot of it boils down to expectation and communication. So firstly, what is the expectation of the patient? Are they expecting that when they walk out of here, they can be paid free? Are they expecting that there's going to be a better range of movement? Are they expecting that there will be a little bit of change? What is the expectation? And I think often as practitioners, and not just chiros, I think practitioners across the board, we don't necessarily spend the time to understand what our patient's expectation is. So I think often that's the first step of where you might get the patient walking out on the front. The second one is communication from the practitioner, and not educating the patient enough to understand, firstly, what they're going to experience, but secondly, what they should possibly experience once they've left your practice. I mean, I would honestly like to believe that 95% of the patients that I treat will feel significantly, if not a hell of a lot better, when they get up off the bed and they leave after their first treatment. That's a wild expectation. I would say that a vast majority of my patients do, but there are certain conditions and presentations where that's not a reality. It's not going to happen. You have either a really chronic long-term pain condition, or the acuteness of that situation dictates that, yes, your function's better, your range of movement is there, but actually your pain is still very much there. Ideally, we don't want patients leaving here feeling more pain than they can bear. That is not ideal, sure. But it may well be a byproduct of what we're dealing with in that situation. Again, if your communication's clear and the expectation's right, you can manage that situation. And in terms of, and as you said, it just opens up a huge debate. Physio chiro. Like, to be honest, there are two completely different positions. And I think on the one hand, on the chiropractic side effects, we've got a very specialized, very focused, very specific approach, which is very spinal orientated. In terms of sports chiropractic, yes, we look at peripheral joints. We look at sports performance and sports function. But in essence, as a chiropractor, our go-to is the spine and the peripheral nervous system. That's when we specialize. That's what we are trying to find out. Where is the breakdown of communication on your nervous system that is related or causing the dysfunction that you're picking up in your body? Now, if we can identify that and correct it, and our tools of correction are the manipulation, using our hands to correct any aberrations or dysfunction within the spine to restore normal function, particularly to the nervous system, but to add on to the musculoskeletal system. And that is our focus. That is our goal. That is what we do.
Just for fun for newbies, yeah. When you go down a spine, if there's a specific like L5 S1 disc, if you perhaps treat it or click it or you go out the spine, that it I guess I suppose at a very simple level, is there a connection of this specific area of your spine connects how your pinky works and your elbow? I'd like to say, just give us a fun little like
100%. And you'll often find, let's think of a good example. Often a good example is patients who have Achilles issues. Okay. And I see a lot in our triathletes, certainly our long distance road runners, your court players, tennis, paddle, squash, and long histories of Achilles injuries, Achilles issues. Now, by and large, generally, they've gone to physio, they've gone to bio, and those muscles have been stripped out, the tendons been treated, so the cars come home, and you've got
your keys as we don't.
that's not a tendon.
Just to confirm, yeah.
Often, they would have had the books thrown at them. They'd had shock wave therapy. They've been needled. They've been stretched. They'd be, you name it. And they kind of manage this Achilles pain, which is incessantly there. Now, there's a very, very strong neurological connection between the bottom end of your Achilles, your soleus and gastroc muscle coming down onto that Achilles tendon that is innervated by your L5 nerve. Okay. L5 nerve being the last lumbar nerve coming off the base of your lumbar spine. And in most people who have any kind of office job, sit in front of a computer, drive, spend most of the day sitting, there is compression down onto the L5 disc.
So, just for simple terms, if you can think of our spine, the L5 is the lowest nail of the spine. It's the last disc, which is connected to your.
So we're sitting, there's compression of that disc, which then decreases the hole on the side where the nerve comes out. And it doesn't necessarily mean that that nerve is being damaged or compromised in any other way than the whole way it comes out has got snort. Now, there's a lot of structures that sit in that hole. There's a bit of body fat, there's arteries, there's veins, there's lymphatic drainage, there's other little nerves. There's a lot of stuff that goes through that hole. And where it used to be nice and big and wide, now it's probably half the size. That area gets a bit claustrophobic, a little bit cramped in. And the best way to describe it is that nerve gets a bit claustrophobic and starts to go, on the second, I'm not comfortable within the space.
So now what do you do when someone comes to see you?
So to try and get the function and the mechanics back into that area, it's great. So we try and create a little bit of space on that disc, either using a sort of flexion, distraction type of techniques to try and open that disc a little bit. Whether demonstrably there's a change in the side of that disc or not is probably irrelevant, but we create a little bit more space. And in doing that, it opens up the whole enigma.
So then a sort of one fix wonder. It's a process.
And it also said returning the function to that area. So you can't just look at the disc on its own. You've got to look at the two joints at the back. And they all relate, but they talk about a three-joint complex. So it's the two facet joints in back and the disc in the front. Now, if one of those three are not working, it's going to affect the other two. So we need to create a little bit of space and a little bit of function back onto the disc. We need to make sure that those facet joints are moving and functioning properly. And the better we can do that, the less disturbance or distraction there is on that nerve. Now, you may not be symptomatic. There may not be any indication whatsoever in terms of you as an athlete as to why that L5 should be compromised, why you get Achilles issues. But that's why you need to go and get it assessed and checked to make sure that that L5 nerve is firing and functioning properly, and that is not what's contributing to the Achilles.
I think that little example just, it's so extraordinary that it actually think that your spine and the correlations connection of your whole body is connected to your spine. So it's extraordinary that, so obviously, you've over 2 decades, know the correlation of where and how to manipulate. And it's fascinating,
No, it absolutely is. And that, please don't get me wrong, this doesn't negate that there may well be a muscle issue, that there may well be degeneration in the joint, and that there may well be some scar tissue somewhere that's also creating pull. But if your central command or instruction from your brain is not able to get to the muscles, to the soft tissues, to the joints, you're completely dysfunctional. You can't possibly expect that knee to function properly, or that ankle to do what it's supposed to do, or that Achilles not to be painful. So that communication has to be there from the brain to that receptor site. And the better that communication is, the better that person heals well is to be. So in terms of sports injuries, absolutely, I happy to treat sports injuries, help you recover from a muscle tear or a pull or a ligament injury.
On that note, is it somebody who, to the average person out there that perhaps doesn't know the difference between a physio, a chiro, and a neurosurgeon, what advice can you give the average corporate going person's sports person who has pain? When do I go to a physio? When do I come and see you? And when do I go? Do you know what I mean? Let's just say time here, instead of going to the physio, then the physio to the chiro, or do you know what I mean? Huh? How can you speed up the process with giving that powers or tips? And
So obviously my perspective on this is very biased, but being a sports chiro or chiro with a hell of a special interest in sports, and I do peripheral stuff in terms of shoulders, elbows, wrists and hands, knees. Your mainstream chiro, or call it your family practice chiro, may not necessarily do that peripheral stuff. They have the capacity to do it, but they may not be that especially interested or have any specialization in that. So that, just to make that clear up front. So sports chiro would look at your peripheral joints and the function of those, and couple it back to the spine. Personally, I think there are people, they have personalities and characters that respond better to physio, and those respond better to chiro. You could present exactly the same issue, and this person who responds or resonates better with chiro will get an amazing result. They'll go see a physio and they're like, really? And similarly, this person who responds incredibly well and resonates with physio goes to chiro and goes, oh, I'm never going there again. So there's a personality and a character association that without a shadow of a doubt exists. Some people resonate to chiro, some people resonate to physio.
and you work with both. You work with neurosurgeons, physio.
Absolutely. But so that doesn't really help you if you've now got an injury. Like, do I go chiro?
So there isn't a rupture.
One of the most, I think, horrific generalizations, and like gives me the crawls every time we hear it, is like physios do muscles, chiropractors do joints. Like if I was a physio, I'd be absolutely peeved by that. Just as much as I am as a chiro being peeved by saying, no, you only deal with joints. Or I just can do it. So by and large, physio is very good at dealing with soft tissue. So muscles, ligaments, joint capsular issues, things like that. They're very well versed in that. Where physio has its biggest contribution in terms of the injury scenario is the initial phase of injury through the first phase of rehab. So it's reducing inflammation, slowly getting range and function back to the tissue and the joint, and then passing that on to the bio who does second and end phase rehab. So that's the strengthening and conditioning stuff on top of that.
Which they here
You actually put into where them supposed to brilliant. And so that doesn't really, in terms of that analogy, that doesn't really give space for the chiro to fit in there. Apart from the fact that if you're dealing with mechanical breakdown, and then the neurological input to that tissue. So where there's been deficit that may well have led to their injury, and if that's not restored, the likelihood is they're going to be injured. And that's where your sports chiro in particular, but your chiropractor has
you said believe again when you say dead for the regimes that hasn't healed correctly, and then it's
so I always say in a lot of my presentations, you're dealing with, and I worked with the British Masters Athletics Federation for years when I was in the UK. You're dealing with a sprinter who sprints every single day of their life. Okay, They are conditioned, they are trained, they are elite at what they do. One random day, they're running the 100 meters, and at 80 meters, bang, they get the sniper in the back of the hamstring, and they pull up. And they can't know, like, that's thing done, they pull their hamstring. How does that happen? And often this analogy goes back to the poor impala running across the field. I mean, does he all of a sudden pull up with the hamstring? So what is challenged within the athlete to now create an injury? So in essence, there's only two things that will change. Either the origin and session of that muscle has changed. It's either got shorter or it's got longer and put more strain pressure on that muscle. Or the communication to that muscle has changed. And what the brain is telling that muscle to do and what is coming out the other side are two different things. And because there's a mismatch in that communication, next thing something fails and it's the muscle tissue. Next thing you're a tip. So it's all well and good putting that athlete in and now going to work on the hamstring, releasing the muscle spasm, smoothing out any tissue that might have been damaged, get the inflammation down, and the muscle heals beautifully. Have we changed anything else other than that? So have we gone and looked at the communication? Is the communication where it should be in terms of what the brain's told that muscle to do and what is actually coming out at the other side where the message is?
As you saying, you can do this.
That's what we do. So chiropractic now,
And very specialized.
and this is often where the I don't want to call it conflict because that sounds really aggressive, but where the headbutt comes in between physio and chiro in that sports space is that the impression is that a chiros want to come in and take over. No, we don't. I mean, we're happy to come and assist with soft tissue, mobilizations, a massage, stretching, taping. We're educated in that stuff and we can help with that. But where our value add comes in is making sure that the communication from the brain via the peripheral nervous system is as crisp and as clear as it can possibly be to that muscle. So that you're not going to tear it, you're not going to pull up, you're not going to get injured. So it becomes injury prevention and performance enhancement rather than treatment management and repairing damage. And that is where the nuance is, because I'm very fortunate. I've got probably 20, maybe 30 physios who refer to me regularly, and we have a very good understanding and a very good professional relationship. The patient gets seen to me, it's sent through this physio. I know exactly what I need to do. I need to restore the mechanics and the neurological patterns that injury, and the patient goes straight back to refit. After my job, the physio carries on with this. And that's how it should be. There should be this resonance and this cross-packing and multidisciplinary environment for the improvement and the betterment of that athlete and that patient. As much as I'm happy to treat sports injuries, I get more passion and joy out of seeing a patient who doesn't get injured and can perform at their best, time in, time out. That's where we need to be. We shouldn't be having reams and reams of patients on our beds because they've torn hamstrings and torn ligaments and all the rest of it. It's usually because of a breakdown in communication or a change in the biomechanics. And if we're not addressing those, that athlete's just going to get injured again.
I think just for a quick 5 rundown, like Achilles tendons you mentioned, if somebody has a hamstring pull, what tips and advice if they have it and they're suffering from it now, they come in, they see a chiro, physio, like run 3, 4.
So I guess, and so your hamstring analogy could be any other muscle in the body, same sort of thing. So your approach is obviously, say there is an injury. You got a grade 1, 2, or 3 tear.
You keep it warm, you put ice on it.
So traditionally we always put ice on there. The research seems to say that compression's actually better than ice. I'd get some compression and some ice on there. Ice definitely makes a difference, whether it's psychological, physiological. Ice definitely makes a difference. Compression makes a massive difference. So the sooner you can do compression of that tissue,
Reduce the sweating, tame the sweating. When you say compression, you mean like timing and the all around it.
It needs to be firm. And not to the point where you feel like you're strangulating the tissue. Just needs to be firm. That firmness contains the extent of the inflammation. If you don't contain that, the inflammation is allowed to proliferate into that tissue, and it'll go as long as there's swelling or bleeding or whatever. It'll keep going until it stops. So the sooner you can put the compression on there, it's a bit like if you cut yourself. Get some compression on there, the wound sort of firms itself up and the bleeding stops. Same sort of concept. Get the compression on there, contain the swelling and the inflammation. And the ice also helps with that. So initially, we want to try and contain the inflammation. The quicker we can drop inflammation down, the quicker we can get the healing process going. There's one caveat. We like to take anti-inflammatories.
I was going to ask.
We do not take anti-inflammatories. You know, OSFDR. In as much as it stops or breaks down, slows down the inflammatory response, the way it does it is on a chemical level. And on a chemical level, it now disturbs the next phase of your healing. So, yes, it slows down inflammation. Yes, it stops the inflammation. And you feel better because there's not so much swelling. But the next phase of how this tissue repairs and recovers and you rehabilitate it is now being cannibalized. So, get the compression on there, get the ice on there. If you read those specifically, if you really need to take something because it's that sore, by all means take a painkiller if you need to. But if you can get through the first 48, 72 hours, chances are you probably don't need to take a painkiller. Okay.
And so it's very anti-inflammatories.
Yeah, no, they're not those. They're a quick fix. And look, when you're that kind of pain and you're chronic inflammation and it's the only thing that gives you relief and you can get to your day, I get it. I'm not going to judge you on that. But in terms of injury repair and to get the best response out of your body and the best repair process, stay away from anti-inflammatories. Also, the effect that they have on your kidneys and your liver. If you've got any issues there, you're not going to really anti-inflammatories. And so initially, your focus is on trying to get the inflammation down, try to calm that area down. You may then need to help with some remodeling in terms of the tissue that might have got damaged. So if there are some tears in the fiber and some gentle massage, some gentle soft tissue work, and using some physio modalities and that would certainly help that speed up that process a little bit better, get you healing on the track a little bit better. Some gentle stretching and start getting a little bit of normal function and movement back into that tissue is part of that progression. Consistently, that inflammation should be coming down and you should start feeling a little bit better, range a little bit better, less tenderness and sensitivity in the tissue. Also within that phase, you should be addressing the mechanical component and the neurological input. The sooner we can get better neurological input to that tissue, the quicker it's going to heal as well.
How do you do this?
So from a chiropractic perspective, that's trying to identify where the breakdown in that communication is coming from. Most of the time, it's as the nerve exits the spine, very close to the joint, very close to the disc. If there's any kind of dysfunctional disturbance in that joint or the disc, it's going to have an effect on the transmission of information in that nerve. So that is most obvious base going to clear out first. That doesn't mean that there isn't disturbance further on that nerve. So there could be some scar tissue somewhere. There could be a previous injury that's causing a disturbance on that nerve.
If there are previous injuries, can you pick it up, heal it, and
addressing those, freeing up where there's scar tissue or restriction of the fascia or whatever it is that may be causing a disturbance on that nerve. The analogy that I use, and it resonates quite nicely, is that it's a bit like if you were trying to read something. In the corner of the room, there's a light flicker, and you just can't focus on what you're reading. That's what's happening to that nerve. So by all means, take an MRI, take an X-ray scan, and go and do an ultrasound. You're not going to see a physiological, pathological change to the nerve or damage occurring on the nerve. It's a physiological disturbance on the nerve that is distracting the quality of information that's going on that nerve. So imagine it like a superhighway, okay? And that should be crystal clear, clean, smooth, no potholes. Yeah, that's it. That nerve should be able to send that information at lightning pace straight down that superhighway, straight to its receptor site. Now, every time there's a pothole or an exit or a bit of a dip in the rip, that slows down the transmission of that information to that receptor site. And literally every nerve in your body has something along those lines going on.
Which is all connected to your spine, which is
But on a day, it's variable. We did away with it. But now, if you're an elite 100-meter sprinter, the slightest disturbance or blemish on that communication system is going to affect your performance at all. And that's the level that we need to be working.
And that's the level you have with world,
As your elite athletes.
yeah, you work with elite athletes like the World Games or the,
So there's a lovely story that I like to tell about. How did you get into it? Like, yo, tell us. So this athlete that I treated at the World Masters Championships for years, I was there. He was a 250, 400 meter runner when I was in the UK. And he was a 200 and 400 meter runner, European and world champion. And I treated him regularly at the British champs, world indoor outdoor champs, European world indoor and outdoor champs.
200, 400 meter.
Yeah. So, and he was in the 40 to 45 age group. So, I mean, he's still, he's running world-class times. Wow, he is an elite athlete of note. And I hadn't seen him for a while through the off-season. I'd last seen him at, I think it was the World Championships at the end of the season before. So I hadn't seen him for about 4 months, 4.5, 5 months. And I was working at the British Masters Athletics Championships, and he rocked up there. Great to see him, hugs, all the rest of it. How you been? Yeah, I had a couple of issues during the off season, health issues, but I'm fine. So I said, what do you mean? No, he had a adrenal tumor. So the adrenals, well, tell me who didn't. He had a tumor that they had identified, and they decided to go and remove it. He is Afro-Caribbean background, and generally Afro-Caribbeans, when they scope a scar, they get what they call keloid scarring. So it's a raised scar that forms. Okay. Anyway, he said, I've been great since. I've had no issues since, and I'm back to training. Congrats. So obviously the championship started. He was going through the heats. First heat was great. Second heat, didn't really feel like he was really firing and was some of this. So he came in to see me. He said, Doc, I don't know what it is. I found also in training recently, I can get to sort of 70% of my max. And then something's sort of slowing me down. I just don't feel like I hit my top gear. So I have a little look at him. I've checked him out. And there's a few things coming off the base of his lumbar spine. His L4, L5 are not really firing as well as they probably should. But nothing hectic. His alignment's a little bit out, which you probably expect because he hasn't done tune for a while. So I treated that, checked him, and everything seems to be working beautiful. Fiery pattern was back up and running. His range of movement, everything looked great. Went back out. I think he was now he was through to the semis. Comes back. You wait to warm back. He did all his drills. He said, Doc, I'm feeling great. Brilliant. Went to the semis. Same thing happens. Semifinals, 70%. And he managed to limp through and he got his place in the final, but he's not feeling great. Comes back in, and everything I checked initially is back. I've treated this guy for a couple of years, and he really genuinely responds beautifully well. So for him to have dropped it, having just gone out and done some drills and warm-ups and run 100 meters, we've missed something here. What's going on there? Check him out again. Turns out that there's active scarring where they've gone in and removed the tumor of his adrenals. Now, I'd heard about active scarring, didn't really know exactly what it was. When I subsequently went and researched it, there is so much research on active scarring. It'll blow you mind. I mean, it'll take you probably decades to read through it all. And they don't know why certain scars are active and hot. But basically what happens is when you've got an active scar, it almost is like a trip beacon, and it emits a signal in your system, which then distracts and disturbs your nervous system. So when your brain's sending the message to that hamstring that it needs to fire in 100%, by the time it gets there and it's been distracted by this trip beacon, it's only 40% or 50% of messages come through the brain. So when you're firing at full pace in 100 meters and you need to push harder to get through to win it, and you don't have 100% capacity, you only have 40% capacity, something's going to give. And bingo, that's the hamstring. So I then got stuck into that scar. I mean, you're not going to remove keloid scarring. But the theory was if I could change the signal coming off that tissue, maybe we've got half a chance of this thing holding and not distracting from the message that should be getting to the hamstring. So spent a bit of time, worked it, retested it, sealed to have done the trick in terms of changing the signal coming off the scarf, adjusted him again, sent him out and said, listen, we're good night. He ran the 100 in a world record time, and he well, it was a British record time at the British Championships, but he got his gold, and he felt perfect.
And you were his personal chiropractor.
Well, I was at those championships, so he lived quite far away from me. So there was a chiropractor he used to use there, but when he came to the championship, I would treat it. But from that point onwards, for the rest of the season, he never had an issue with his hamstring, and that got me then researching active scars. But whether it's a scar, whether it's a fascial disturbance, whether it's degeneration in the joint, the minute there's something that's not normal within the system, the likelihood is it's emitting a signal that's now going to distract your nervous system. Now, if you don't remove that signal or change that signal so it's no longer a distraction, you're not going to get that full fiery pattern to whatever the muscle or area that your body's trying to communicate with. And again, on a day-to-day basis, that's not going to bother you or me. Go at a fit level. When you're running the 100 meters, as a Formula One racing climber, that little blemish and that little miscommunication is what's probably either going to lead to an injury or...
Well, it's fascinating you have the opportunity to actually treat patients at that level. I mean, it's incredible.